Well, welcome everyone to this second webinar as part of the Raindrop seminar series. So we'll have in total 3. The last webinar was focused on genomics and genetics research in this area, and today we're focusing very much on teaching in the area of rare disease, and we will hear about some really interesting approaches in a little while. So my name is Thilo Kroll. I'm Professor of Health Systems Management in the School of Nursing, Midwifery and Health Systems, and I'm have the pleasure to chair this morning, or I should say afternoon now. So I won't use a lot of words now, I think, and drag out some of the introductions, and probably just welcome our panel and introduce everyone who will speak today. I have some more elaborated, I think, profile descriptions for Suja and for AJ, but I also know Cheryl is there, and I Googled Cheryl a little bit, but I couldn't find too much. You're hiding too much, So probably we'll ask you, Cheryl, to introduce yourself. Beyond what I found. So, but to introduce sort of Professor Amy Jayne McKnight. So, and obviously that is a very also very rich research profile. So Amy Jayne is joining us as a professor of molecular epidemiology and public health at the Centre for Public Health at Queen's University of Belfast. So our very welcome guest from Northern Ireland, who we're working very closely with, and in this All Ireland initiative. And Amy Jayne runs a very busy research lab. I don't know how you do it, I think in terms of juggling all these things that you're involved in, you always stay so calm and always seem so relaxed. So there must be some magic bullet, but maybe we'll learn a little bit about that from yourself as well. And so there's a lot actually to say, and we probably will run quickly out of time about AJ. So as Professor Amy Jayne McKnight is also known, we just know her as AJ. She helped to develop the Northern Ireland Rare Disease Implementation Plan. You're part of the Northern Ireland Rare Disease Stakeholder Group, developing the Rare Disease Action Plan for the time after 2020. You're the research lead at the Northern Ireland Genomic Medicine Centre, and your team has worked on a number of really molecular risk factor tools and so on. So without, I think, further ado, before I said I would introduce the full panel first. So I'm going to Suja next. So Dr. Suja Somanadhan is our very own at UCD, our assistant professor of children's nursing. And she's a registered children's nurse and registered general nurse and a nurse tutor as well. She's worked, has extensive experience in working as a clinician in pediatric healthcare settings in Ireland and abroad, and has developed a really focused program of research and education in the area of rare disease, and particularly, I think, with a focus on children's and young people's health, but also across the lifespan. And we wouldn't be here if it weren't for Suja, because Suja brings everyone together into a network. And this is what we call the Raindrop Network, the Raindrop Initiative, which is the rare disease partnership in the Republic of Ireland. And there's also a partnership in extension that goes across Ireland, the island of Ireland, which is the so-called RDSnET, or the Rare Disease Research Engaging Social Science Partnership. And so Suja has led a number of research projects and also prioritization exercise in terms of research priorities in the area of rare diseases, and recognized very much the importance of patient and public involvement. So the very engaged working with individuals and families affected by rare diseases. And last but not least, Cheryl McGuinness, is also one of our own. I have to say, we can claim her as well, nursing student at UCD. And I found that you're also, I think, very fundamentally interested in anything scientific and science related. So you've a keen interest in medical science, molecular science, and so on. You're also an animal lover, and you have a family, and you have also very first-hand experience with rare diseases. And yeah, if you wish to add something to that, because I couldn't find more in the shortness of time, please do so.
Yeah, there's nothing much more to add. You've basically covered it there. But yeah, I was diagnosed in 2012 with my first rare disease, and then since then I've had another one added onto it, which comes with its own problems. So yeah, that's it really. So I do understand from a patient point of view as well as being a student nurse as well. So yeah.
Thank you for joining us today. Thank you, Cheryl, from the panel. We'll come back to the. Great, thank you. So we'll come back to the panel, but I think first of all we'll hear from AJ. So I'm so used to call you AJ, so it's hard to do the whole spiel with Professor Jayne McKnight, which I can do as well, but AJ is much easier. So I'll hand over to you, I think, to start us off, and then I think Suja will talk about her program of work.
Right. So hello everyone, essentially, and Thilo, thank you for the welcome, and Suja, thank you for organising. I guess it's a pleasure to share with you a little bit about some of our rare disease research and some of the teaching initiatives that we've been establishing in academia, largely based in Queen's University Belfast, but also working with some of our colleagues in Ulster University. We're always very keen to conduct stakeholder-led or stakeholder-driven research that's really going to lead to improvements for people living and working with rare diseases. It's always very much an evolving work in progress, and we're very keen to take on board views and suggestions from the wider public in terms of what we could do better or what other approaches we might consider. As Thilo said, I'm based at Queen's University Belfast, largely working out of Belfast City Hospital and the Royal Victoria Hospital. So the UK Rare Disease Framework and the UK Rare Disease Strategy define a rare disease as a life-threatening or chronically debilitating disease that affects 5 people or fewer in 10,000 and requires special combined efforts to enable people to be treated effectively. There's lots of different definitions of rare diseases, and in Northern Ireland, this is the one that we follow. There's more than 9,000 different rare diseases that have been identified, and there's more than 5 new rare diseases described in the medical literature every week. And that's really important because it's as we learn more about the rare diseases, we get to know more about different ways to treat them, different ways to diagnose them, different ways to help people living and working with rare diseases. Rare diseases might sound rare, they might sound unusual, but actually there's more than 450 million people worldwide who are living with rare diseases. Rare disease will affect at least 1 in every 17 individuals in Northern Ireland, which equates to about 6% of our population, and that's more than 110,000 people. We do know that rare diseases range in frequency, so there might be a rare disease where there's only 1 person diagnosed with that individual rare disease worldwide, ranging up to the more common types of rare diseases that affect perhaps 1 in 2,000 persons. We do know that together, rare diseases represent a worldwide problem that has very significant implications for local healthcare policy. Many of you will be very familiar with the problems that are associated with rare diseases. So for example, more than 75% of rare diseases affect children. And we know that approximately 30% of rare disease patients will die before they reach 5 years old. Many adults are living with more than 1 rare disease, and again, that brings lots of complications in trying to juggling and looking after each individual rare disease. And unfortunately, we know that research into rare disease has been historically very poor. This is often due to a lack of funding where rare diseases are seen as being rare. Why should we put funding into something that affects a small proportion of the population? There are few clinical trials for rare diseases, and those that do exist are often very difficult to access for patients. The clinicians may not have the time to contribute, and the sheer volume of information that's also requested for participation in clinical trials really prohibits a large number of people being involved. We do know that most rare diseases do not have an approved therapy, and again, that makes treating them very complicated. We know that early diagnosis and appropriate interventions significantly improve patient outcomes, and these are typically with longer-term decreased overall costs of healthcare, although initially the orphan drugs tend to be more expensive than more common drugs like aspirin or paracetamol. There's an increasing public awareness about genetic testing and the uses of that, and I know we heard about that in much more detail in the first session. But certainly there's greater public awareness and demand for genetic testing. And we do know that even with a diagnosis, it can be very difficult for healthcare professionals, patients, carers, and families to actually obtain relevant, accurate information and support, with many charities and support groups either being very highly specialised or being non-existent. I said that early interventions substantially improve the quality and life expectancy for individuals living with a rare disease, and that's very true. But in terms of diagnosis, more than half of patients feel that they don't receive enough information at diagnosis. As rare diseases frequently affect multiple organ systems, patients are usually managed by more than one healthcare professional across a range of medical specialties. So a survey in 2017 in Northern Ireland showed that 15% of individuals see 5 to 10 doctors, with 1 in 20 persons attending more than 10 doctors. 71% of patients did not feel they received sufficient psychological or social support associated with their rare disease. And we know that 66% of patients travel over an hour to clinics, and that might be a clinic that lasts for 5 or 10 minutes. We do know that in terms of rare diseases, our healthcare systems are not designed to support rare diseases. There are major unmet health and social care needs, and that leads to lots of opportunities for research and service improvements. We do know there's a significant lack of awareness associated with rare diseases, where knowledge is often reserved for patients, families, specialist healthcare providers, charities and researchers. We really do have to do better, and one of the initiatives in Northern Ireland that we've been using to improve services and improve research and really work with our local charities, patients and families is the RDSnET project, which is supporting rare diseases throughout all communities. In Northern Ireland, we had a rare disease plan launched in 2015, and that was following on the heels of the 2013 UK strategy for rare diseases. One of the key features of our Northern Ireland Rare Disease Implementation Plan really reiterates the UK-wide strategy to support the education and training programmes that will enable our health and social care professionals to better identify rare diseases, to help deliver faster diagnoses, to better identify rare diseases, and to provide better access to treatment pathways for patients. And really reflecting the importance of improved education for healthcare professionals, national rare disease plans in England, Scotland, Wales and Northern Ireland, and the Republic of Ireland all support commitments to improvements in this area. So in practice, we've seen massive changes over teaching and education in the last decade. For example, in the last 15 years, we've redesigned the undergraduate medical curriculum in terms of genetics and rare diseases more than 3 times. Each time we've included more information on genetics and more information specific to rare diseases. Queen's medical students were founder members of the Medics for Rare Diseases. We introduced real experience sessions that were delivered by people living and working with rare diseases. And these were done in traditional large lecture theatres with more than 250 students, and in small group teaching where we have 5 to 20 different students in the class. We introduced a very successful preparation for practice session, which is aimed at final year students just about to step onto the wards. And really that session is about providing key information and links to important tools to help them identify and manage rare diseases. In terms of supporting education and training in 2021, where are we now? We provide specific rare disease lectures to all years of the undergraduate medical curriculum. These are in terms of traditionally taught sessions. Newly introduced for this year are long-term case studies, where students will take on board a particular case where someone has a rare disease in their family. They'll research that in depth over a matter of many weeks in small group sessions, and that has input from multiple specialties, including families. Students also have the opportunity to undertake optional special study modules or placements. We have specific rare disease lectures taught to our undergraduate biomedical and human biology science students, and that's important because these students are often the ones that are going into the laboratories to help diagnose rare diseases. And we're also very keen to get our students interested in rare disease research, which is a very dynamic and rapidly evolving field. We have shared rare disease undergraduate, postgraduate lectures across multiple universities. We provide a range of public lectures and different engagement activities like the Pint of Science, the Northern Ireland Science Festivals, for example. We provide a lot of postgraduate sessions with continued professional development, and often this is done in collaboration with Royal Colleges. And we're currently in the process of trying to develop harmonised rare disease teaching tools across Ireland. So this is very much a work in progress. Many of you will recognise the iconic Golden Gate Bridge, which took 4 years to build. A major problem for our rare disease community is getting a diagnosis of their rare disease, and I know that won't be unfamiliar to many of you. While the Golden Gate Bridge took 4 years to build, the average time to get a diagnosis of a rare disease is more than 5 years, with half of patients receiving at least one wrong diagnosis before they get the right one. And really obtaining the correct diagnosis and relevant expert guidance has a significant impact on the development of each patient's rare disease care pathway, including consideration of appropriate medical interventions, access to the right public services at the right time, such as financial or educational support, and really connecting with relevant rare disease support groups. We do know that 1/4 of rare diseases have a molecular cause that's known, while approximately 80% of rare diseases have a very strong genetic component. But we need much better tools to identify rare diseases for these patients. I know you heard in the last session about how whole genome sequencing may become the new standard of care. And whole genome sequencing is really a brand new approach that's come in over the last 5 years. It's technically and economically feasible, and it's got huge successes for diagnosis and therapy. Using this approach, we can get a 40% increase in yield of diagnosis for patients with a rare disease. Often these are many patients who've gone through individual repeated tests that have been negative. It might be this, we'll do a test, oh, it's negative. Well, maybe it's the other, we'll do a test, oh, it's negative. This new whole genome sequencing approach offers the opportunity to do one test that can provide lots of information. And as I said, up to a 40% increase in diagnostic yield. Using neonatal diabetes as an example, the 100,000 Genomes Project was a UK-wide NHS transformational programme to try and provide whole genome sequencing linked to electronic medical records to help improve diagnosis for patients with rare disease across the UK. And it led to dramatic improvements for many families. So as an example here, we know that mutations in more than 25 different genes can cause neonatal diabetes. So rather than a baby being born and identified as having neonatal diabetes, now it can be born, and using new genomic technologies, we can identify new genetic subtypes which significantly change the therapy options provided to those individual children. So examples on the slide here, and I won't go through them, but 5 different specific mutations leading to very dramatic therapies. Some of them are receiving a liver transplant, a bone marrow transplant, a STAT3 inhibitor, or insulin supplements. 5 babies, 1 diagnosis of neonatal diabetes, and 5 very different treatment strategies. Genetics is a very powerful tool. In terms of research-focused genetics, we know that our 100,000 Genomes Project led to the new National Genomic Medicine Service and Test Directory being developed. Matt Hancock, who's the Health and Social Care Secretary for the UK, announced his ambition to sequence 5 million genomes in the UK by 2023. We have access to UK Biobank, which is a national and international health resource that contains detailed genetic data linked to very rich phenotyping, so clinical information, social information, about 500,000 volunteer participants. Brand new on the scene is the Accelerating Detection of Disease platform, or the AD platform, which is really a brand new pioneering program that aims to recruit 5 million volunteers, inventing new ways to detect and prevent the development of diseases. And this is also known as the Early Disease Detection Research Project UK. In terms of clinical practice, we now have whole genome sequencing commissioned for many different types of rare diseases. We can also do large base panel tests, and these are accessible through the NHS Directory of Genetic Disorders. We have rapid genome or exome sequencing for acutely ill children with a likely genetic diagnosis that started in 2018 or 2019, so a brand new development. Results are typically issued in about 9 days with about a 40% diagnostic rate, enabling optimized care protocols for those very young, severely ill children. In 2018 in the UK, non-invasive prenatal testing was introduced for the screening of trisomies and sex abnormalities. So essentially just taking a small blood sample from the mother, we can get the fetal DNA and assess if the baby has a range of different genetic mutations. And we know that tracking down rare diseases through families is still fundamental to the study of many rare diseases. But we do know that our genetic tests and options to identify rare diseases are getting much more complicated. And talking about getting much more complicated, sometimes it's more than just changes in DNA sequence. Sometimes DNA sequence changes just aren't enough, and we need to look beyond projects like the 100,000 Genomes Project. We need to look at things called omics. So genomics is the study of changes to your DNA. Another commonly studied omics is epigenetics, where we look at the interaction between the DNA that you inherit from your parents and those links with your social environment, your diet, your smoking, your exercise, your weight. How do those things interact? Other things like transcriptomics or proteomics or phenomics, the study of observable traits in people. We need to bring all of this information together to help improve the diagnostic rate for rare diseases and to help us identify new therapies. There's lots of different studies out there that are suggesting the best way to conduct a multi-omics study. The particular slide here, and again, the slide will be available for you to see after the event in detail if anyone is interested, is from one of our current PhD students, Katie Kerr. And when you get your rare disease diagnosis, then where do you go? What happens next? Often people are left feeling as though they're really floundering, having no idea where is best to turn to next. And some of our research, again by another PhD student, has shown that patient voices reveal a lack of information is really a critical issue around diagnosis. People saying the biggest problem is there's nothing wrong with the child, lots of different wrong diagnoses. Parents feeling as though they have to do the research, perhaps even traveling to conferences internationally because no one else is interested in looking after their child with a rare disease. Parents also emphasising how diagnosis is very vital to get much needed support for the family. As an example of where getting your rare disease diagnosis can be very powerful, the story at the top is from Jessica, or the link at the top is from Jessica's story. Jessica was one of the first children to receive a diagnosis from the 100,000 Genomes Project. And at the link, her family talk about really what it means to them and how it will affect their treatment. The 100,000 Genomes Project now has more than 122,000 samples processed, with more than 112,000 genomes sequenced. And we got actionable results, so changing the therapy for rare disease patients where previous traditional genetic testing did not identify the cause of the rare disease. This new approach did. So getting the right diagnosis very much empowers people living and working with rare diseases, provides relevant information, facilitates the best treatment opportunities, enables connections with rare disease focused support groups, other people living with similar circumstances or challenges, and helps people connect with the right experts internationally. Getting the right diagnosis also allows families to effectively plan for the future, whether alone or in combination with health and social care professionals. Lack of information is another very big problem unless a person knows where to look. You don't know what information you're actually seeking or where you're going to find it. We do know that more than 80% of individuals report accessing relevant information is very difficult. We know that more than 70% of GPs said they struggle to identify or manage rare diseases. More than half of patients have more than 10 medical appointments each year, and there's no clear care pathway or patient journey or linked information systems. We find many patients are having to keep their own records of their healthcare treatment when they say to their cardiologist, well, you've put me on this drug, but my nephrologist who's looking after my kidney says I can't take that. And my endocrinologist who's looking after my other system say, well, no, you can't take that either. It's very difficult often to get the healthcare professionals to communicate effectively between each other, particularly when they're based in different hospitals. Patients, families and carers often have to become expert patients, where patients are very much at the centre of their care and are informing healthcare professionals and driving and campaigning forward for better treatment. We have focused on some of these areas of research. So the GP focus was of particular interest to us because in many cases for adults with a rare disease, the GP is the one person who coordinates the results and the tests between lots of different healthcare professionals. And we found that 100% of GPs who responded to the survey had not undertaken any rare disease training from they qualified. And they were very keen to see the provision of information and support from specialist good signposting services. There was a significant lack of coordination, and that led us to develop a rare disease toolkit for GPs, really highlighting red flags as to when a rare disease should be considered and directing GPs towards appropriate information sources. Voices from our Northern Ireland rare disease community also suggested communication was a major area that needed improvement. Again, this is work by one of our PhD students, Kroll, where patients are saying, the letter we received with their diagnosis was very blunt. It wasn't sensitive. It didn't address us. It was a line and a half of information, which was very vague. No information was ever given to me about my rare disease. I had to do the research online. Really, to find another person with the same disease as me would be so important. I was laughed at by a doctor asking for more information. Patients really are going online or going onto social media or talking to friends and family to try and find information, and it's hard for them to know what is reliable, what is accurate, what is trustworthy, and what isn't. It's not just a problem for our patients and families, it's also a problem for our healthcare professionals who may never have come across that particular rare disease before. The current rare disease support in Northern Ireland has been perceived as inadequate through multiple different surveys, and again, this is work by one of our postdocs, Julie McMullen, who suggested some improvements that are needed to support people living and working with rare diseases, as suggested by our local rare disease charities. So within our local rare disease groups, they suggested having a local person involved was very important, such as a local ambassador in individual areas. They needed to host conferences and more information days and tailor the information that was delivered to be country or geographically specific legislation. They wanted a free database with all rare genetic conditions listed with appropriate links, and help keeping staff and the charities well informed about services and improvements, so better interactions with healthcare and social care providers. Really, what came out very strongly was that services need to be co-developed with families and health and social care facilitating families and health and social care providers to co-develop services. And outside the groups, then the rare disease groups thought that doctors should recommend rare disease patients to contact accredited collaborative groups for support. We need better information sharing between groups to remove redundancy. We need better access to information for therapies, aids, grants, education support, clinical trials. That doesn't necessarily have to come from individual charities, but could be something shared. We need more collaboration in raising awareness and policy changes. Creating a local registry for all rare diseases is highlighted as a major priority. And things about running more educational visits, more international events, more public engagement events. Regular workshops and roundtable discussions were ranked very highly. And one thing we have to remember is there's health and social care professionals dealing with rare diseases. There's the patients with the rare diseases, but we also need to consider the carers, many of whom care 24 hours a day, 7 days a week. And some of the biggest challenges that were identified through a survey, focus groups and individual interviews was carers are really concerned about what's the future going to look like? What about health and social care services? Where do I find the right information? Where do I get access to the right resources? Where do I get decent support? Where do I know more about what financial support's available, what medication people are taking, what mental health support is available both for the person I care for and for myself? And some of the themes that came out of that work was that we really need to remember the carers in all of our research and service developments. Often very practical issues would be welcomed, and improvements in health and social care support. Respite support, particularly at the minute in the middle of COVID, where that respite support has been withdrawn, can't be underestimated. Carers really would like to have a helpline as well where they can contact someone for immediate support. Very topical in terms of the COVID-19 rare disease research. So much of this research has been conducted remotely due to social distancing requirements. We have an open study looking at the Cocoon project, working with colleagues as Suja and Thilo in University College Dublin, and Karen in Canada, where there's a range of individuals looking at the impact of COVID-19 on home care services. So things like dietetics, occupational therapy, home delivered care, special education schools, for example. We have our impact study investigating the impact of COVID-19 on caregivers and people living with a rare disease. We have studies looking at COVID-19 genetics, genomics, the vaccine responses in people with rare diseases, using data from well-established collections like the 100,000 Genomes Project and the UK Biobank. We have multiple projects undergoing under a RARTech banner. And one of my primary research interests is kidney disease. So under our RegenPEC banner, we have a collaboration with University College Dublin and Queen's University Belfast, where we're looking at the impact of COVID-19 on people living with rare kidney diseases. So in terms of where next for research, well, the three big priorities that come out consistently in all of the research that we undertake is that we need to develop a national registration service for rare diseases. If they're not counted, we don't know the number of people who have individual rare diseases, then we don't know what services are going to be required. We don't know how to contact people to say these clinical trials are available. Are you interested in taking part in research? We know that we need a dedicated online Northern Ireland Rare Disease Information Hub, and this is something we've been talking about from 2013, but is now moving towards an actual real developed information service. And we know that we also need a lead rare disease information coordinator, and our colleagues in the Republic of Ireland are much faster off the ball with that than we are, having their national rare disease office. Consistently top ranked are those top three, but other things that we need is more steps to improve diagnosis. We've made huge changes in the last 5 years, but there's more to be done. We need to improve communication strategies. We need to bring on board big data analyses. There's lots of information out there that needs to be better managed and analysed. Digital social innovation tools, improving support networks, looking at social needs and impacts, improving interprofessional learning. I could go on and on and on. There's lots of different areas and opportunities for research. The one thing I would stress is that we really need to have our diverse stakeholders in the rare disease community working together to ensure we're conducting the best possible research in the most cost-effective, efficient manner possible. My personal opinion is there's no point doing research for the sake of research. We need to do research that leads to real health and social care improvements. So what opportunities are there for people to participate in research? Well, as a student, there's undergraduate or postgraduate research projects. There are summer studentships, and these may be paid or voluntary studentships lasting from a week, typically up to 8 to 12 weeks. There's exchange visits and personal fellowships, and many of us in academia are happy to help students gain or seek funding for those fellowships. We have partnership programs working with industry, where students can get experience of academia and industrial placements. We have partnership programs with public bodies, where perhaps students may undertake some time working in our local Stormont executive or public health agency, for example. People can participate in research as a researcher or as a participant, or often as both. And again, we work with a number of third sector organisations, and for example, charities are often delighted to host students for paid or unpaid placements. So there's lots of opportunities. And I guess that's the end of what I wanted to say today. I'm very happy to take any questions. I will apologise if you get a slower than usual response to your emails. My daughter was born prematurely 13 days ago, and I'm currently on maternity leave, so very sporadically checking emails. And other than that, thank you very much for your attention, and I will pass you back to Thilo. If I can stop sharing my slides.
Thank you very much, AJ. And I think this, I mean, the last slide actually, first of all, congratulations, and of course that is, I guess, the icing on the cake. I think, you're sort of such a power person. I think how you, it's just amazing, anyway, so many congratulations, but also congratulations on the excellent presentation, that you've given us, and the really excellent overview, of the work that's going on in Northern Ireland, which is fantastic. Under your leadership, you've moved so many things along, both in a research area from basic laboratory-based research to the clinical applied arm, and all the way to community-based supports. And you really highlighted the need, the dire need for more collaboration, integration, more targeted communication, education, as well as the opportunities that there are sort of in the current more targeted genomics research and genomic sequencing, epigenetics, and so on. So I mean, it was a whistle-stop tour across the whole field. So thank you very much. What I would suggest, I think we'd probably hold questions until we go into the panel discussion, and listen to Suja first. So maybe to everyone who's listening in today, if you could think of questions, please use the chat box, and we can bring that then into the panel discussion. So if you have any points to make or questions, then please incorporate that in the chat box, and I will pick that up as we go into discussion. So thank you, AJ, and so moving on to Suja now. So we'll give us insights into what's happening here at UCD.
AJ, thank you so much for the wonderful presentation, and thank you so much for sharing that memorable moment with your little baby girl, DJ. So thank you so much, and I know how committed you are in terms of rare disease and rare disease community. And I know I had a pleasure working with AJ for a number of years now. I'm still a kid in the block, I feel, every time I talk to AJ, but I'm very pleased and honored to be working with you in a number of projects, and I'm looking forward to work many more to come in the years. So I'm going to share my screen, and thank you, AJ, again. So again, good afternoon, everybody, and thank you so much, Professor Thilo Kroll, for a warm welcome and a nice introduction for us. And it is my pleasure and honor to be here today at the Raindrop Webinar Series 2, which we are focusing on rare disease research and teaching initiative. And I think Thilo already mentioned, my name is Dr. Suja Somanadhan. People call me Suja, and you can call any way you want. I'm currently working as an assistant professor in children's nursing, and I'm also a researcher at the UCD School of Nursing, Midwifery and Health System. I think Thilo already mentioned I have over 20 years of clinical experience in the pediatric healthcare settings. Even though I trained as a general nurse, I always worked with the children, all the way from neonates up to age group. But at the same time, I have that interest of life course perspective. I think that is very important. You look after people across the lifespan. Sorry. So I just want to say, because I'm representing UCD today, and I know this is an all Ireland webinar series co-hosted between UCD and Queen's. So as you know, UCD is one of the largest research intensive university. We have over 33,000 students representing from 120 different countries. So we are very much a global university, and we have 34 schools and 18 research centers. And there are a number of major themes for the university, and one of them is health. And you can see there are a number of other themes as well. There are a number of research institutes and research centers within UCD. But again, myself and Thilo both are part of UCD School of Nursing, Midwifery and Health System. We also have a UCD IRIS Center, which is the Interdisciplinary Research and sorry, I get confused with the title. Sorry, it's a UCD Health System Research Center we have. So again, we also have a UCD Academic Center for Rare Diseases, which is affiliated to UCD Medicine. So again, I'm not going into detail about rare diseases, but just want to emphasize. So rare diseases often tend to define according to the incidence of the disease. When you think about the European Union, we define rare disease as a condition or a disease that affect fewer than 1 in 2,000 people. In the US, it's affecting fewer than 200,000, which is about 1 in 1,500 people consider rare diseases. So I think AJ mentioned this so beautifully. So I'm not going into detail, but it's important people to have an understanding of what is rare. Rare are not actually that rare. Rare diseases are not that rare when you look at them collectively. Even every time I speak to my colleagues or my friends, they always think, oh, I'm interested in something very rare and it's not exist. But that is very untrue. When you put together so many people living with rare diseases in the world, I know AJ mentioned there's over 100,000 people living in the Northern Ireland. We have over 300,000 people living in the Republic with some form of rare condition, and 1 in 17 people affected by some form of rare condition, some stage of their life. Even I do my sequencing. I may have some kind of rare condition myself. So sadly, pediatric population affect, significantly with the rare condition, because it's a children, and 30% of children with the rare diseases die before the 5th birthday. The reason is in a lot of rare condition in children, they are life-threatening or life-limiting. So there is no curative treatment available. One of the examples is a Batten disease, mucopolysaccharidosis, not all the types, some types. So there are conditions out there, and you will see, the nature of the illness is a life-threatening. So I'm going to ask Justin to play a video. I'm very much a visual person. I think it's nice for us to have this video played. So guys, I'm very different compared to you heard from last week. You heard from genetics expert like Dr. Shane McKee and Dr. James O'Byrne, and today you heard from Dr. Jayne McKnight. So they are very much driven into the research in a different way that I am. So I'm very much, as I said, my background is a nurse. I worked in Temple Children's Hospital for 14 years before I moved to UCD. So I worked in the metabolic unit and endocrine unit, and I come across so many children in Ireland living with one of the rare condition during my time as a nurse in Temple Street. So every time I spoke to the families and their life stories inspired me as a nurse, as a researcher to do work, because I always felt how they manage coming all the way from Kerry to Dublin to care for the child. And also at the time, enzyme replacement were given in Temple Street. That means these families has to drive all the way from Kerry or Cork to Dublin for the treatment weekly basis. So that was a huge challenge. So I decided to do a doctoral study focusing on the lived experience of families, experience of caring for the child with a condition called mucopolysaccharidosis, which is a rare metabolic condition. There are different typology. I'm not going to go into detail of mucopolysaccharidosis. I just want to say this is a rare condition. It's a genetic condition. And you may heard about Hurler syndrome, which is very common, very high prevalence in Ireland, 1 in 10 carrier frequency. There is no newborn screening program for any of the mucopolysaccharidosis in Ireland yet. So when I did my PhD, again, that was one of the first kind to act as an initial inquiry, understanding how the family lives their life. So since completing my PhD, I developed a program of research looking at child and family and how we support them, how we support them across the lifespan. So again, just want to reflect and go back to my own PhD. Again, I'm not that long qualified. I'm only complete my PhD in 2016. So I know this is a mucopolysaccharidosis, but every time I read the themes emerge from the study, I often think about this is inconsistent with so many other rare conditions. So living with any type of rare condition, including MPS, parents are trying to be positive because they are the main caregiver for the child and they have to be there for the family. So for example, here you can see, I have always remained positive. So, and they always spoke about it's a battle. It's a battle to get a diagnosis. It's a battle to live with the rare condition. And you are living in the roller coaster because of this condition is a progressive condition and everything will be good today. It could be worse next week. So that emotional roller coaster they are living everyday life. The stigma of rare disease is something very come across very strongly in the literature and also my own study. The stigma can be visible or invisible. Some of the rare condition, looking at a person, they have some form of rare condition. Some of the condition, they probably have a pig feet. You don't even know because it's all been tied up. Even people living with any other condition, they do have a symptom, it's not presentable. So that is called invisible stigma. But when you think about that, people living with their conditions, there is, especially around the genetics, in the literature and also my own study, people reported feeling guilty, especially parents, is coming through the family tree. They reported from the grandparents to the parent and the child. They always describe about the faulty gene, how they feel about feeling guilty. And also catching up with so they all often feel that their children are not catching up with their peers because the kids are losing the school because they often going to school, hospital for the treatment and management. So, and also their developmental and growth is all they are losing out. So the parents kind of highlighted, how they feel about it. And sometimes the rare condition, the features do stand out, and they often wondering about they as a parent, I'm a parent myself, we want our child to be treated normally. And if somebody treat our child any differently, that is a hard on the family, So it's a normal, they're trying to achieve this normal life balance. Even I heard at the interviews, every time the medical appointment come to the post, every time they open the letter, they feel, they go to the mode of being a parent of a child with the MPS. Otherwise, they are living in this normal life in their house. There is no treatment for there is no curative treatment for all the mucopolysaccharidosis or many other rare conditions. So here in this study they talk about it was a double-edged sword for a family. There is no treatment available for at the time. They spoke about how hard for them to knowing that there is nothing available for their child. And then because they are living in this world of no man's land, they don't know what is going to happen to the child or in the future. So that feeling of the limbo was there all the time. And also another one here is you feel like you are in a box and you can't get out, because as a parent you want to care for your child and you are in there and you can't really get out because you are living in that mode of I'm a mother, I have a child who has this condition. They often talk about hospital, how hospital, I know we as a nurse and a doctor, we look after them so well, and that come across very clearly in the interviews. At the same time, as a parent, think about they're coming in and out in the hospital, and the hospital always bring back the reality that they have a condition. And they often described healthcare system as a revolving door. And then another description is experience of waiting. They often waiting and waiting to get a diagnosis. As AJ mentioned, she was referring back to the bridge. So when you think about the waiting and waiting, take time to get a proper diagnosis. And it says a minimum of 5 years to get a proper diagnosis. And sometimes the progressive nature of the illness, as a parent, they feel like it's like you're watching a time bomb. We don't know when that's going to be explode. So frequent flyer is like a in and out the hospital, and they have to come in. All the specialties are based in Dublin, so they have to travel all the way to Dublin. So that is something they're described as a frequent flyer. Again, I know we have a national guideline how to communicate or a breaking bad news to the families, but still my PhD was in 2013 and 14, I collected data. At the same time, parents told me how they got the diagnosis over the phone. I think that is, as a personal level and also as a researcher, I think it's so important to sit down with the family and to disclose the diagnosis in a more empathetic and compassionate way rather than over the diagnose over the phone. I know, again, National Metabolic Center have a very good support system in place, psychologists, social work, clinicians. And again, majority of the parents I interviewed, even though they eventually came to the National Center, but they were attending different services the time they got the diagnosis. So, so it's just need to be mindful. The experts are here in Dublin. The diagnosis may be given by maybe a GP or public health, we don't know. But again, we have to have a good best practice, how we disclose a diagnosis. Doesn't matter if it's a child or an adult. We need to deliver that in a compassionate manner. Think about you as a patient. How would you like to get a diagnosis? So again, I think I mentioned this in detail. I'm not going to go through that one. So follow up on that study. We also did another one on looking at the parental stress, quality of life, and resilience. So that was a joint collaboration between the Mater, Temple Street, and Crumlin Hospital. So we did a cross-sectional study looking at the families of children with the same condition, because we were very keen to know what about their quality of life, what about the stress, what about where they stand in terms of resilience. We also conducted 2 focus groups with the healthcare professionals working with the children. Think about healthcare professional. Even me as a nurse, I look after so many children, and sometimes on our professional life, we will lose children because there is no treatment. It's a progressive nature of the illness, and sometimes treatment needs to be stopped because it's not working. So there are challenges as a healthcare professionals' lives too. So it's important for us to understand what is there for them in terms of coping and supporting themselves. So we did this study. Again, going back to the parents, there was 31 parents, and the quality of life really reported highly. So I often wondering, is that due to the Irish culture? Because we have a good family support, friends in place compared to other countries. There was a similar study conducted in Brazil, and the quality of life was very poor of these families. And I was wondering, and we had the discussion with a couple of specialists as well. And they're looking at a pediatric inventory for stress. This is another scale we used. The majority of the results shows, the family is often scared. They're often worried about the child condition because of the nature of the illness. They are afraid that child is going to die. So that was something very difficult for family to, that one of the difficult or stressful factors for these families. The resilience reported very highly. So that was something and interesting as well, because these families are living with the condition for a while, and some of the families have even adult people living with the MPS, and the parent are still caring for them. So there is a long, not all the mucopolysaccharidosis. One of the condition called Morquio, which is a type 4, they have a longer life expectancy than other type of MPS. So there are different typology, and every typology present a different way. So I'm not going to detail about the condition. Anybody's interested to know this project, and happy to email. This project report is submitted for a publication, so hopefully will be released very soon. Another one is also available online as an open access, so happy to share. So the key finding about healthcare professionals, again, healthcare professionals I mentioned, the progressive condition, that experience can cause moral and ethical distress for the healthcare professionals. Even I did a 2 focus group with clinicians who care for the children with the metabolic conditions. That they understood the complexity of the illness. They also highlighted the need of coping strategy for both parents and also the healthcare professionals, because there is no formal system in place as psychological support. It's all about informal. When you go grab a cup of tea, you talk to somebody, but there is no official or formal support system in place to talk to somebody in terms of how to manage, how to cope. Think about you are looking after a child or a family, and they are going through a very hard time. We are human beings. We have emotions. It's so important to sit down and talk to somebody about you as a person, as a healthcare professional as well. So it's a both way. Healthcare professional need to we need to have a good support for them. We also need a good support for the parents and the carers and the patients itself. So I have another project running at the moment. Again, it's about child. So think about child, family. Child never exists itself. So child need a family, society, and the support. So it's very important we brought that child-centered, family system-based approach. So here, this project is funded by Temple Street Foundation. Again, this is very much looking at people's experience of living with rare diseases. So we are using different modalities like a music, art therapy, sound play, photo voice interviews. The COVID-19, wasn't great for us because we couldn't get any data yet. We are still waiting, because this project is designed to collect data face-to-face, have the engagement, offer the opportunity for the child to talk about how they feel about living with rare diseases. So we were very much looking at children who is attending metabolic clinic, renal clinic, neurology clinic. Anybody attending Temple Street will have an opportunity to be part of this project. So again, I emphasize it's important we focus on child and family-centered approach. The partnership and collaboration is so important between the healthcare professionals, families. This is an absolutely necessary, because parents are the expert by experience, and the children, even young people, how do we involve them in terms of rare diseases research? Again, it is important to involve school. I'm currently leading on the design and delivery of a module at the national level. Is focused on primary and a complex need. This is a part of a national online training program for special ed assistant. This is funded by the National Council for Special Education. Again, there are so many children attending the schools at the moment, and they certainly need to have a upskill and the knowledge so that they are there to look after the children. So that's something very, very important. The transition is not just about pediatric to adult care transition, it's about a life transition. How do we support the children moving through the pediatric to adult care, and also the school setting and also the community settings? We need to look that transition as a whole, life transition. This is the Raindrop is again a partnership between numerous organizations, and we managed to get a small fund from HRB to do this. It's a collaborative partnership consisting of basic scientists, applied researchers, health and social care professionals, patients, advocacy group, and other support organizations. So we did this as a participatory multi-phase approach. So we looked into how this is we really wanted to understand the need, what we need to be addressed in terms of research priority from a patient and a people perspective living with rare diseases. So there was a number of phases: the consultation phase, participative workshop phase, we had a public ranking survey phase. There are numerous phases. Again, this publication is available online. I just want to highlight, we identified 15 priorities. I'm going to show that in the next slide. And that very much mirrored some of the key recommendations emerged from the National Rare Disease Plan for Ireland consultation process. So it's very much we are consistent what we found, and that is already being reported. So support at the time of diagnosis came very strongly. Diagnostic test, patient voice, economic and social impact, psychosocial impact of living with rare diseases, what is out there, community-based support. And these are the priority emerged from that multi-phase project. Again, if anybody is interested, please email me. There is a publication available online. It's an open access publication. You can straight download and read yourself. There's so much to talk about. So I'm going to keep going. I'm conscious of the time. I really wanted to thank you everybody who participated the Raindrop, which is a rare disease research partnership. The lived experience of patients and their families make a unique contribution to the understanding of rare diseases. I think AJ beautifully mentioned that earlier. I think we can't do anything, research, teaching, even clinical management without families, because they are the expert, they know better than anyone else. So it's very much of that, building that partnership and collaboration with the families and the people living with rare disease is very important. And Raindrop, I have to say, very much the patient and carer's voice is placed at the center stage for this partnership. And still we are working, even today's webinar is part of the Raindrop initiatives. So this is the publications. Again, where we go next, we have to say there are so many rare conditions, over 8,000. There are so many people living with rare diseases, and we need to develop the integrated care. So we are very much interested in developing diagnostic perspective, living with, and integrated care. So at the moment, Queen's, UCD, and a number of other collaborators, we are shortlisted for a doctoral program in rare disease through HRB. Again, we haven't submitted a full application. This is the shortlisting process. So I'm very excited, because I was looking at a chat earlier. I know Anne Lawler, one of my colleagues from the rare disease community, and she mentioned about how many PhD students are doing PhD from Northern Ireland, which we don't have many here in terms of with me or with our school yet, but there will be more in the future. I know there are a lot of work is happening in the medical research, biomedical research. I know there are numerous people are working rare disease research all the time. I'm just looking at the life course perspective. So you can see that we have a collaborative partner, the National Rare Disease Office, NIH. We have a Center for Rare Diseases in the UPMC Children's Hospital. We have a Northern Ireland Partnership Task Force, a Raindrop Consortium. So we have a numerous partners for this project, and hopefully we will be successful. So we are almost there. We are working towards, myself, AJ, and Thilo is working very closely on this project at the moment. Again, AJ mentioned this. We are also partnering with Canada, looking at how the COVID-19 is impacting children with rare or complex needs and the home care package at the moment. So if we haven't completed the survey is open until 28th of February. Please, your voice is very important. Your say is very important. If you can't find the link, I'm happy to share the link with you if you can contact me, please. So there are a lot of teaching information is available through the European Society of Human Genetics for healthcare professionals, students, patients, families. So there is so many things available there. I just really want to draw your attention to this Society of Human Genetics, which is recently launched a website, Genetic Educational Material and Resources. National Rare Disease Office is Ireland, and Eileen Tracy, Professor Eileen Tracy is the clinical lead for rare diseases. She worked really hard on the establishment of Rare Disease Office and the clinical program for rare diseases. The office launched an e-learning module for healthcare professionals, which is available online. Again, I really want to highlight, we don't want to reinvent the wheel. If it is something already there, please make sure you access them. There are 6 sections within that module. Rare disease teaching, we have a School of Medicine. They have an elective module. Again, this elective module is very much targeting medical student, final year medical student. That was developed by Associate Professor Paula Byrne. So this was developed in 2012. My understanding, this is the only module available for rare disease in the Republic of Ireland. So I envy AJ's, they have so many program and teaching happening in the north side. So we will be hearing more learning from AJ as we go along. So I really want to thank Anne Lawler to coming to children's nursing students, and she speaks to children's nursing every year. So we managed to incorporate genetics and genomics and a number of genetic conditions as part of the undergraduate children's nursing program. So I do bring families and they share the stories with the students as well. So we build the baseline knowledge of genetics and genomic and the practice into the nursing, children's nursing practice. And then they often hear from the families as well, their stories. So again, the last few weeks ago, we had this patient public involvement in rare disease teaching workshop. Again, I really want to say thank you to UCD HRB McKnight Award. We got a small seed funding, which helped us to enable research consultation, co-design research, teaching material for people living with rare diseases for the students as well. So it's very much a co-designed approach. So we used the launch cycle, which is a design thinking model. Again, looking at what is the problem, who has the problem. These are the 5 questions we were looking at. Again, overall, how they rated, they felt is really good and extremely effective in the way of engaging the PPI rare disease workshop. The families and patient advocate came online and we had they shared their stories. Prior to that, they received lectures and very in-depth knowledge and understanding about genetics and genomics and a number of genetic condition and management. Then we invited families to share their stories. So that was kind of a PPI style workshop we facilitated. And you can see how the students rated the lived experience story, extremely effective as majority of them said. Again, you can see what did you like about the workshop, personal experience. The information was very powerful. And you can see that here anyway. So interaction between the student, faculty, and speaker. So there are a lot of students. There was around 75 students attended this workshop between the children's nursing, undergraduates, and the postgraduate students. Then we were asking about what are the 3 type of product they would like to see. They told me asked me about a t-shirt. We are going to design this in the future. Animated campaign, app, campaign again, educational track and app, an online disease catalog, a system tracker app. There are so many things, ideas emerged from this workshop. It's unbelievable how, I know we are all living in the virtual world, but with the Zoom and with the support of Justin, I know we are able to do so many, innovative workshops and ideas. And even, I know we couldn't create prototype, but this is the ideas we could generate and then we could develop in the future. And you can see how. So one of the ideas came from the student was All Ireland Student Network for Rare Diseases. And we felt, I know there is a medic for rare diseases in the UK. And we feel rare disease is something, is a very collective and you need so many people to look after a child or a peer person living with rare diseases. So it's important to have an All Ireland Student Network for Rare Diseases. So I'm going to welcome one of my students, Cheryl, to join me now, and she's going to talk about why it's important from a student perspective. Thank you, Cheryl.
Thanks, Suja, and thank you for having me today. Well, when I heard that you were doing this and you'd invited me, I was over the moon because, as you know, I was actually put in contact with Suja because I myself have a couple of rare diseases, and they weren't diagnosed till later in life. One of them was diagnosed within 11 months, which compared to what we've been saying today was relatively quick. The other one I'd actually been living with all my life up until I was diagnosed at 32. It was just put down to aches, strains, stuff like that. So that one was ignored really. And the fact that with involving families, you can, get more out there because there is more than one doctor needed for any kind of rare disease. Because I've been under cardiologists, yet I haven't got a cardiology issue, but because I've got something linked to my issue, I need to see them. I've been under an endocrinologist, a hematologist, nearly every doctor I've been under, and I've only got a neurological condition and a joint condition, which actually goes more in detail to actually the collagen in my body. And there's no specialists in Ireland for either of my diseases. There's people that have interest, but no one that actually specialises in them. And my information has been got from groups of people who have had these issues themselves. They haven't been able to go to a medical person or a professional to know about these things. So I basically got my diagnosis through online groups, finding through them a medical person who has an interest but isn't qualified in it, who's been able to advise me. And again, like you said, the stigma that I've received is my conditions don't exist. My conditions are in my head. My conditions are because I need to lose weight. And then when I have lost the weight, they're like, well, you've still got the condition because you've lost the weight too quick. So everything's contradicting, and you do need people that really understand any rare illness, really. And like we've said, the multidisciplinary teams are the major thing. And to be able to see several people that do have an understanding is massive, because it is all, you do start to believe it's all in your head. You start to believe, am I really going mad? Am I making this up? Am I a hypochondriac? And to find anyone, even if it's a friend or like Suja, a teacher, or just anyone that don't even have to be involved in the medical industry, just someone that will listen to you and say, yes, I understand you, I believe you, is a massive thing. They might not be able to help you, but just having that belief of someone. And then, like with Suja, it leads on to involving more people as well. And I'm really excited at what Suja's wanting to do, because it is something we really need. And from a student nurse and a patient perspective, it's to have someone come in with me as a student nurse, and they're like, oh, no one believes me, and I've got this, and they think I'm making it up, and you'll say, oh no, I do believe you. The look on their face, that's better than any doctor fobbing them off with a medication, because they're like, oh my God, someone actually believes me, someone understands me. So yeah, I'm so excited to see how far we can go with this, because it's something that's really, really well needed, and it can affect and have such a positive outcome with so many people's lives. So yeah, I'm so pleased. Thank you for including me.
Yeah, I just want to highlight so why we need a all Ireland student symposium, because when you think about, as Cheryl just mentioned, so many people are involved in the care of a child or a person with rare diseases. So we need a cardiologist, we need a nurse, social worker. So it's very much health and social care professionals. So we are targeting any students in all Ireland interested to join this network. You are very welcome. And we will be, myself and AJ will arrange a separate meeting and see how we can support you in terms of develop this network, support each other, improve your knowledge base and understanding, and support your colleagues, or peer, because there are so many people, in the college, they probably need a support. And, once you understand, they feel good as a friend, and it's very much to support each other. And also there are so many patient organization and community would like to have you as a student. There are so many opportunity to work, even voluntary base, even research or teaching. There are opportunities. So I really wanted to highlight, very important to stick together as a student, to support and learn from each other and learn together. And as I said, together we are stronger. So I just really wanted to highlight important. And this is one of the photographs we took at UCD Symposium. And you can see so many students and faculty come together to support that event, and including Justin himself. So I really wanted to say one more thing. HSE has information for a healthcare professional. So I'm only here talking on the behalf of the UCD, but very important that you go back to the HSE. If you are a healthcare professional, you want to know more information is available online. And finally, an easy guide to rare disease was launched last year. Myself and AJ and Dr. Avril Kennan was here last week. We were there at that launching event, and it's a really good beneficial document that provide an insight into what is rare diseases, explain very well the insight into the people living with rare diseases and what is out there in terms of policy and practice and research. So I would recommend, it's a downloadable, it's a very important, very nice document. So I really wanted to say thank you everybody, and these are my contact detail. Anybody want to contact me, and I'm happy to share anything I have, and happy to support the community of rare diseases in all Ireland perspective. And thank you very much for listening to me.
I am Tristan.
Angelina.
Nama saya Shafiq.
Regina.
Habari asubuhi, Javi.
Jeg Jon Christian, og jeg bor I Norge.
I live in the United States of America.
In Australia.
Malaysia.
No Brasil.
Tunaishi, Kenya.
My passion is for fashion and design.
I love to dance.
Menyusur hutan.
Para viajar e descobrir novas culturas.
Anapenda kunitazama nikipuliza mapovu.
Jeg elsker idrett og spille spill med familien min. Minhas paixões são minha fuga quando as coisas estão difíceis.
Ada hari-harinya apabila melakukan perkara yang biasa akan jadi sangat susah.
When your disease makes you feel isolated.
It's difficult to walk.
Å være med på laget.
When I'm tired.
Afraid.
O controle da doença pode ser desafiador.
Atau mengecewakan bila saya kehilangan masa.
Muda muhimu sana.
But we learned to be resilient.
Para apreciar os pequenos detalhes que me trazem alegria.
Kumwona mtoto wangu wa kiume anavyofurahi tunapoenda nje, nikijua anasikiza hadithi na sauti zilizo karibu.
Mencari titik perhubungan dengan masyarakat yang tak pernah saya sedar wujud.
Å være uavhengig på grunn av menneskene rundt meg.
Their fierce support.
Sua bondade inabalável.
The big love.
Mine venner.
Keluarga.
Enfermeiras.
Doctors.
Support workers.
Assistenter.
Mashirika ya wagonjwa.
Together, we are a strong community.
Nimeweza kuelekewa.
Histórias compartilhadas que me libertaram das dúvidas. Og ga meg selvtillit.
I am Tristan. I live with sickle cell.
I'm Angelina.
And she has CASC, a neurological disorder.
Saya Syafiq dan saya hidup dengan ectodermal dysplasia.
Regina, eu tinha leiomiosarcoma, câncer raro.
Huyu ni Harvey, ana SMA, spinal muscular atrophy.
Jon Christian og jeg har OI, medfødt benskjørhet. Esta é minha vida.
Suara saya.
And I am more than my disease.
We are rare.
Kami ramai.
Nós somos fortes.
And we are proud.
I think that is the voice of many, many people. And this is a webinar series very much to support and raise the awareness of rare diseases across the globe. I know there are very few people, but it's okay. Very few people come together, we are stronger. So I'm going to hand over to Thilo. Thank you, Thilo.
Well, thank you very much, Suja and Cheryl, for your presentation as well, which was excellent. I think, looking at all the good work that's going on and also how it's growing, what potential is there. And if I can just maybe say, I think your presentations, Cheryl and Suja and Amy J, sort of, I think highlighted that actually three things need to come together, I think, within you. And one is, I guess, the knowledge and expertise that you bring, to the table, and the systematic studying and building of the evidence. Whether it's in the basic science or applied science or in teaching and learning, and then the second bit, I think all three of you actually personify very strongly is passion. The passion, the emotional side, the drive to really make a difference, and have an impact. And then the third, which is also linked to the passion, I think, is the compassion. The care. Wanting to make a difference, not for yourself, but for the community of people living or affected by rare diseases. And ultimately, we're all, part of this community, and whether we have a diagnosis or not, but everybody, it's everybody's business and everybody should care. And it's great to see the direction of travel, I think, where all this work is going. And I see sort of a bright future ahead of it. And I think with lots of opportunities. And if certain things might not work along the way, then we'll find a plan B. But as you've highlighted, there's a great network and great collaborative links emerging between different key groups and who are now constantly, I think, in that process of communication. But we won't have much time left, but I just would like to invite any questions or any comments from the audience. I know we have a few here in the chat box. So Anne basically and Lal are highlighting, the emphasis on the lived experience. Once you have a diagnosis, living with a potential significant impact on physical, intellectual, and sensory impairments, and living a life with disabilities. So not to forget that, that has implications on, and also requires particular supports particular recognition and particular assistance and technology potentially, you know, to so that children, adults with disabilities are adequately supported. There's great excitement, obviously, around, you know, the opportunities for more PhD research, but not only at that level, you know, really sort of supporting sort of the education and training initiatives and projects at various levels. Just again, if there's if there are any questions, you can type them in the chat box. If not, you can direct them afterwards directly to all the presenters, all the panelists, I would say. And while we're waiting maybe for some questions to come in, I would just maybe hand over to the three of you, to Cheryl, Suja, and AJ, to maybe say if there are up to three takeaway points from today's session. What would you like the audience to take away? I mean, there were so many excellent points that you made, but the three high-level takeaway messages. Maybe start with Cheryl.
Yeah. Well, yeah, like you said, there was loads, but the biggest one, like we've all suggested or we've all stressed, is that including the family. You're not just dealing with the patient on their own. I mean, even me at my age, I look to my dad for so much support, and he sometimes needs things explained to him just as much as I do for him to understand it. So the family, definitely, you can't forget the family. Again, understanding that not one doctor is going to solve everything, or not one doctor is going to help you on their own. You know, again, you need more than one doctor to give input, and they need to be communicating. The amount of times I've had where one doctor's put me on one thing, I think it was AJ was given that example. One doctor puts me on one thing, another doctor says you can't take that because you've got this, or you're taking that as well. Sometimes I've got as far as the pharmacy and they've said you can't take that with that, you know. So again, they all need to communicate. And I suppose the third thing out of everything, there's so much.
If there are only two things, if there are more than, no pressure.
Well, I suppose the third one I could do is the stigma. The stigma is a big thing, because again, with one of my conditions, one day I can be bouncing around doing everything, the day after I can barely walk, and that's a big thing with me, because you do get looked at. You're like, well, yesterday you were fine, there was nothing wrong with you, why are you crippled today? You know, why can't you, you know, the amount of pain, you're crippled in pain, you can't move, why was yesterday okay? You know, so there's a lot of stigma with that, because you do get thought of, you putting it on. So yeah, so the stigma is a big one as well. So that's my three. So.
Thank you, Cheryl. Yeah, thank you very much. So maybe going to AJ next.
Thanks. So I guess the one thing I'd probably stress across everything is that it's very much, we need a collaborative, partnership-based approach. It needs those networks of people working together really to do the best research and to drive forward the change, so that once we have the research, we build the evidence base, then we can actually implement change. Can I sneak in and take this opportunity to say congratulations to Dr. Katie Kerr? So some of you may know Katie, who was a PhD student of ours, and she's presented at a number of the rare disease events over the past few years, and she passed her Viva this morning for a PhD, so she's now Dr. Kerr.
Congratulations. Well done.
So I know some of the attendees would like to wish her congratulations.
Yeah.
Literally this morning, so hot off the press.
It's great news. But you don't get away from the other 2 points, or is it a 1 point that you have left? Nice distraction tactic, but.
Well, it was worth a try. I think we really need to engage with our policymakers and the practitioners, people who are delivering the change, to see, well, we have a wish list of what's ideal for change, but actually what's practical to implement, what can be done in the short, medium and longer term. And I think that's very important as well.
Great. Thank you. Okay, let you off the hook now.
You're a hard taskmaster.
I know. Last but not least, Suja, your 3 points.
Yeah, I know I have 1 minute, so I will be 1, 2, 3. That's it. So I think I echo what AJ said. It's a collaboration and partnership. And I know myself and AJ had a couple of meetings, and you were involved in that, Thilo. We need to develop that collaborative and all Ireland approach for rare diseases, because the population is representing the island of Ireland. So we need to come together as a team and focus on research, education, and teaching. And again, for research, we need more funding availability. Again, I was at the transnational call for European joint reference one. So European joint rare diseases, they launched a program, but we are not part of the call. So we can't be, we can't take part. So that is one of the downfall. Again, looking at the people experience of living with rare diseases from island of Ireland, we are missing that opportunity. And we can't even part of any other countries because we have not got the fund to join that. So that is kind of drawback. I think that need to highlight at the Health Research Board and other Irish Research Council. And the policy and practice makers is very, very important. We all need to connect and work together. And even with education, I know myself and AJ and the team in the Ulster and UCD's discussion developing an undergraduate nursing program. Module looking at the one I'm looking here is integrating genetics and genomics into nursing and midwifery practice. So we need to develop that kind of specialist training in nursing as well. The current waiting time for a genetics is 2 years. Even that is not good practice. And if a nurse is trained as a nurse specialist, and they will be there for the child and the family or even person living with rare diseases to disclose the diagnosis and support them when they need it. So at the time, we don't have a specialist nursing practice at all in the country. So anyway, there are so much wish list I have, Thilo. It's a never ending. And thank you so much for the opportunity.
Thank you very much. All the presenters, everyone on the panel, everybody who attended today, Justin for setting this up, for the technical support, and yeah, looking forward to the next seminar. I think webinar will be next week? Yeah,
next week. This time, living with rare diseases. So the people are coming together, and they are, the people living with rare diseases going to share their story. It will be a really nice, day for everybody to hear from people. I think that is very important. I myself or AJ or, we can't share the story. You have to hear from the people like Cheryl, and there are many other people will be involved next week.